This presentation covers the basics about drugs given intravenously for induction of anaesthesia. The three main agents in modern use are propofol, thiopentone, and ketamine. Propofol produces a rapid onset of anaesthesia, it has a short duration of action, and it produces clear-headed recovery with minimal or no hangover. Propofol's short duration of action is due to its high volume of distribution and body lipid. Clearance can be significantly slower after a prolonged infusion. Propofol is metabolized in the liver, and the metabolites are cleared by the kidneys. Propofol has a number of adverse effects. It causes hypotension, mediated through reduced systemic vascular resistance and mild reduced contractility. It also causes respiratory depression and often causes apnea, and it causes a profound depression of airway reflexes, which is often helpful to the anaesthetist to minimise the risks of laryngeal spasm when intervening with the airway. And it can cause involuntary movement, seen as myoclonic jerks, and epileptiform movement, sometimes at induction of anaesthesia. Propofol can cause severe hypotension in some patients, notably people who are hypovolemic or have severe sepsis. The drop in blood pressure can be significant in patients who have pre-existing coronary artery disease, as it causes a related reduction in coronary artery perfusion pressure. And hypotension can be serious in patients who have pre-existing congestive cardiac failure. Most anaesthetists would avoid propofol in patients with egg allergy because the emulsion contains egg phosphatide, and also in patients with nut allergy because there is soybean in the emulsion also. From the 1930s until the 1990s, thiopentone was the dominant intravenous anaesthetic agent. It's a barbiturate, it comes in powder form, it's diluted with water. It produces a rapid onset of anaesthesia. It also has a short duration of action, but it does have some hangover effect in contrast with propofol, and it doesn't suppress airway reflexes as effectively, which is what gives propofol a significant edge in modern use. Thiopentone has a short duration of action after a bolus dose due to its high volume of distribution. Its elimination half-life is prolonged, however, at 11 hours, so recovery from anaesthesia can be very slow after a prolonged infusion. It's metabolized in the liver, and renal clearance of metabolites, only about 1% of a dose of thiopentone is excreted unchanged in the urine. Adverse effects of thiopentone are cardiovascular, hypotension, again due to reduced systemic vascular resistance and contractility, although the hypotensive effect is less pronounced than with propofol. Thiopentone also causes respiratory depression. It causes relatively poor suppression or even heightened upper airway reflexes at induction, and this can lead to laryngospasm or coughing if the airway is instrumented before anaesthesia is deepened with volatile agent. If thiopentone is inadvertently injected into tissue rather than a vein, it can cause tissue necrosis, and if it's injected intraarterially, the solution can crystallize, causing vascular occlusion and gangrene. Thiopentone should be used with caution in hypovolemic patients, although it causes less blood pressure depression than propofol. Also in patients with severe sepsis and with coronary artery disease and with congestive cardiac failure. There was long a legend that thiopentone, being a new anaesthetic induction agent, was responsible for more deaths at Pearl Harbor than the Japanese were, because it was used to anaesthetize hypovolemic sailors for emergency surgery and resulted in profound hypotension and cardiac arrest. But this is probably just a myth. It should also be avoided in porphyria because it can induce alanine synthase, causing a porphyric crisis. Ketamine is quite different from thiopentone and propofol. It's an NMDA receptor antagonist. The other two agents interfere with the function of GABA aminobutyric acid. It can be used as an analgesic in small doses, but is an anaesthetic in bigger doses. It has a rapid onset intravenously, and after a single dose, the patient will emerge after 10 or 15 minutes. And emergence is not clear-headed, and be associated with confusion and hallucinations. Ketamine is less likely to cause cardiovascular instability, so it's the agent of choice in patients who are suffering from, for instance, hemorrhagic shock or severe sepsis. It has sympathomimetic properties, so it results in a rise in systemic vascular resistance and an increase in heart rate. This helps to preserve the blood pressure in unstable patients. Ketamine produces minimal respiratory depression, and airway reflexes are maintained even when patients have obtunded consciousness. As a result, ketamine can be used as a sedative or an analgesic in fairly extreme situations. It's commonly used by medical retrieval teams in situations like extracting people from car wrecks to provide analgesia while the things are being cut away, for instance. And most famously, it was used as a sedative for the children who were rescued from deep in a Thai cave complex, and it allowed them to be extricated safely from the flooded tunnels. Ketamine causes intracranial pressure to increase, so it should be avoided in patients with pre-existing increased intracranial pressure, such as people with head injuries. And because it's sympathomimetic, it can exacerbate hypertension, and so shouldn't be used in patients with pre-existing hypertension, including women with eclampsia or preeclampsia. You can download a PDF with all this information on it by looking on Microsoft Teams in the New Start section, or you can go to the RAH Anaesthetics website and look under Induction New Start Resources tutorial for New Starts.